In this section, I will be discussing the problem, extent of the problem, agent of transmission, of the prevalence of hepatitis A among American travelers in the United States from 2013 to 2018. Slide 1, the problem. Traveling is a part of an individual's everyday. However, when you travel internationally, it is putting yourself at risk for diseases such as hepatitis A. Rural areas such as countries like Central America, South America, Africa, the Middle East, Asia, and the Western Pacific are all more common for hepatitis A. These areas are highly endemic in particular parts. Typically, the reason that these areas are more endemic is because the hygienic and sanitary conditions of the area. The infection rate is seen to be less in areas of higher socioeconomic levels because of proper or more access to clean water and availability of the hepatitis A vaccine. Shown is a map where hepatitis A is typical. In this slide, the extent of the problem will be discussed. Morbidity and mortality. The rates of hepatitis A have declined dramatically since the mid-1990s due to the implementation of recommended vaccinations to those at risk of the infection. In the year 1990 to 2004, mortality trends show hepatitis A being the underlying cause of death on 1,436 death certificates. The deaths were shown to be the highest during the year of 1995, 142 deaths, according to the Journal of Infectious Disease. 2003 resulted in the lowest number of deaths, being 54 deaths. The average annual mortality rates were 32% lower during the post-vaccination recommendation period than the pre-vaccine period. The number of hepatitis A cases reported in the United States showed a decline from 1,670 reported cases in 2010 to 1,239 reported cases in 2004. Extent of the problem Part 2 will discuss economic impact. In 2015, a model was conducted by researchers to assess the cost-effectiveness of hepatitis A vaccination programs in the United States. The model represented a decrease of cases through the use of routine vaccinations and the amount of cost efficiency. On average, universal routine hepatitis A vaccinations prevented approximately 260,000 additional infections, 170,000 outpatient visits, 5,000 hospitalizations, and 200 deaths annually, and had an incremental cost-effectiveness ratio of 21,223 per quality-adjusted life year. The numbers stated represent a high number of prevention cases. Through the use of vaccines, it is shown that the universal vaccine for hepatitis A was a resource of prevention and cost saving. In this slide, the agent of transmission will be discussed. An enterovirus is defined as any of a group of RNA viruses that typically occur in the gastrointestinal tract, sometimes spreading to the central nervous system or other parts of the body. This includes those causing polio and hepatitis A. The hepatitis A virus is an enterovirus from the Picornaviridae family. The Picornaviridae family is a cause of a wide array of illnesses compared to other virus families. The virus structure is typically small in size, ranging from 18 to 30 nm, non-enveloped, icosahedral shape, and consists of a single-stranded RNA hepatovirus. About 10 to 12 days after contraction, the virus is able to be detected in the blood and is excreted through the biliary system to the individual's feces, where the concentration of the virus is present. The photo represents a structure of the virus, including the capsid, RNA, and relative size of the virus.
Clinical symptoms and signs of hepatitis A include fever, fatigue, loss of appetite, nausea, vomiting, and/or joint pain. It also includes severe stomach pain and diarrhea, jaundice, for example, yellow skin of the eyes, dark urine, clay, bowel movements, anorexia, and malaise. Symptoms tend to appear between 2 to 6 weeks after exposure to the infectious agent. In some cases, an individual may be sick up to 6 months. This may lead to individuals being too sick to work and too sick to earn an income. Modes of transmission. Transmission of infection is a way a pathogen, such as a bacteria or a virus, comes in contact with an individual either directly or indirectly. Some modes of transmission for hepatitis A include ingesting the virus from food or drinks that have been contaminated with the small, undetected amounts of stool inside. Transmission may occur in a person who has close contact with someone that they are taking care of whom is ill, and transmission may also occur through sexual contact. Transmission is likely to occur in countries where hepatitis A is very common. The diagram on the top right corner describes hepatitis A reports by risk exposure and behavior in 2015, where we see sexual contact and food and water outbreak cases to be significant. Moving on to control of disease. For primary prevention, it includes receiving hepatitis A vaccine because they are safe and effective. Also, taking 2 doses of the vaccine in order to maximize protection against hepatitis A. And timing. There should be roughly about 6 months in between both doses of the vaccine. Now, who should get the vaccine for hepatitis A? Basically, anyone who is unvaccinated because they are susceptible to getting hepatitis A. Travelers, especially those traveling to areas where hepatitis A is very common and where there are high hepatitis rates. All individuals who have come in contact with the virus to reduce the chances of acquiring hepatitis A as well. Moving on to control of disease. For secondary prevention, it includes screenings and getting tested for hepatitis A, working with those individuals who are high-risk population due to their age, gender, race, or nativity. Also, practicing good hygiene to prevent contamination with the hepatitis A virus. For example, washing your hands after using the restroom, making sure that you are washing your hands when being in contact with food items, and just getting used to having a good hygiene when touching areas that may be contaminated. Next, we have tertiary prevention, which includes treatment. Usually, a doctor will recommend rest, adequate nutrition. They may also recommend to take many fluids. In addition, some people may require medical care in a hospital. Some individuals require months to fully recover, as they may be more susceptible or they may have a lower immunity compared to others. That concludes our clinical symptoms, modes of transmission, and control of disease.
Moving on to the host risk factors, being fairly prevalent among American travelers, hepatitis A factors include a lack of hygiene, poor sanitation, not being vaccinated, and ingesting food or water that has been contaminated with hepatitis A. An example of this could be a contaminated individual who has hepatitis A touches an item that an uninfected individual will ingest. Also, waterborne outbreaks can also be an example. Those who have not been vaccinated or wish to not be vaccinated are at a higher risk for contracting hepatitis A, especially while traveling under the conditions listed before. According to the Stanford Health, hepatitis A is sometimes called traveler's disease because it is the most frequently occurring vaccine-preventable infection in travelers. Environmental factors play an important role in the vulnerability of hepatitis A. Developing countries' characteristics match the description of host factors for hepatitis A. Poor sanitary conditions and underdeveloped sanitation systems are usually in these countries, as well as a lack of safe drinking water available. Traveling abroad and traveling to underdeveloped countries put an individual at risk for hepatitis A. While traveling, many American travelers encounter different cultural items that they may be interested in. Environmental variables include consuming food that is out of the ordinary that may be dangerous depending on where the food came from and how it was prepared, drinking any liquids with ice cubes that may
not been through proper water sanitations, specifically in Mexico. And hepatitis A is prevalent in these areas, but not limited to Africa, Asia, the Mediterranean basin, Middle East, parts of the Caribbean, Eastern Europe, Central America, South America, and as stated before, Mexico. Hepatitis A is geographically distributed into areas of high, intermediate, and low levels. An example of high would be developing countries with poor sanitation conditions. Intermediate would be countries with transitional economies and regions where sanitary conditions vary. Low would be areas of high endemicity and isolated populations like religious communities. The picture displayed explains which level each country is at. As you can see, America is low, so when American travelers go abroad, they are very at risk. Moving on to socioeconomic factors, they affect the vulnerability of individuals becoming victims of hepatitis A. The most affected areas are ones with disadvantaged socioeconomic conditions. Relating socioeconomic status to sanitation problems is approximately 37% of the world's population today does not have access to improved sanitation, meaning there's a significant proportion of the global human population that lives with hepatitis A that can thrive due to socioeconomic status of where they live. For temporal variation, the linkage to American travelers sparked the studies to see if there's a temporal pattern in hepatitis A. FAERS noticed there are particular months out of the year where hepatitis A numbers are reported higher than usual. Climate and behavioral factors are also contributed to this pattern. Travel increase in the hot months, usually in the summer, to endemic areas are a part of this temporal variation. Increase in travel to areas with a lake or body of water present that can be a host for hepatitis A are also a temporal variation.
As looking at this graph providing data on incidence of acute hepatitis A rates by race and ethnicity from the years 2000 to 2013, it is clear that Asian Americans and Hispanic Americans have higher rates than other ethnicities. It is suspected that many of these cases are attributed to frequent visits to relatives in regions where hepatitis A is highly endemic. Adamson and colleagues state that underreporting is frequent among these groups visiting friends and relatives because they may be disenfranchised or less willing to access the medical system for symptoms or treatment unless they are very ill. Costs associated with obtaining travel health advice or purchasing vaccines and medications prior to leaving the country were reported as deterrents. It is important that epidemiologists keep in mind the commonality of underreporting among these high-risk groups to make sure that they are clearly represented. Cities with large populations of Hispanic or Asian travelers, such as California, should create public travel centers where low-cost or free travel advice, vaccinations, and treatments are provided. This can allow people who cannot afford preparation before traveling or treatments after traveling to gain better access. This would also allow epidemiologists to gather more accurate demographic data on hepatitis A. Lack of knowledge of the importance of vaccination and proper sanitary precautions remain to be the main reason travelers contract hepatitis A. Louis and colleagues found only 14% of Americans receive vaccinations before traveling to regions where hepatitis A is prevalent, and found the most common reason that infected persons did not get vaccinated was because they either did not know they could or should get shots. Epidemiologists and health education specialists should consider using traveling websites as a platform to spread awareness. This could be effective since traveling websites reach a large population of people in one facet. Louis and colleagues recommend implementing links or pop-ups of health recommendations for travelers, alerting them to diseases endemic in certain regions. When travelers select tickets or information for regions where risk of contracting hepatitis A is high, an alert like the mock-up one created in the right corner should pop up alerting them of the risk. Vaccination failure is also a risk which requires much more research. Vaccination failure can be attributed to a variety of causes, including issues during manufacture or storage and clinical failure. The true rate of vaccination failure is unknown because information on vaccination status has not been systematically collected during hepatitis A surveillance. New surveillance methods should be implemented where hepatitis A vaccination failure is reported to assess the extent of the problem. Gathering this data can allow epidemiologists and health specialists to recommend additional methods to prevent vaccination failures. This could include additional vaccine batch checking protocol, stricter storage rules, or making sure vaccinations are efficiently transported. We deserve the $100 million to further research on hepatitis A because this disease has been around for centuries and continues to affect millions of lives every year. With funding, we will be able to create new surveillance, prevention, and vaccination efforts, as well as maybe fully control and eliminate hepatitis A. Travelers are not the only group at risk in America. Marginalized people like illicit drug users and the homeless continue to have disproportionate rates of contraction. With funding, we can make sure all people, regardless of social status, ethnicity, age, or gender, can be protected against hepatitis A.